We focused on the response to interferon alpha in patients with essential thrombocythemia. Indeed, our group has shown a few years ago that interferon alpha was a good therapy for polycythemia vera patients in that way that it was also able to eradicate in some patients the clone having the JAK2V617F mutation. So now we were interested to see if we could have the same impact on the clones in ET who are bearing the calreticulin mutations. And indeed, we found the same very nice response with a decrease in the calreticulin mutant allele burden in ET patients treated with interferon alpha. Furthermore, we could also check for other mutations that are, mostly found in PMF patients, for example, like A6L1 mutations, IDH1 and 2 mutations, etc., that are usually associated with a poor prognosis in primary myelofibrosis, but some patients with ET also have this kind of mutation in addition to calreticulin mutations. And we could see that when an ET patient has calreticulin plus another mutation in one of these poor prognostic genes, the response to interferon was much lower and much poorer. So there's also in ET an impact probably of these additional mutations on the response to therapy of patients and maybe on their outcome. There are, I think, to my knowledge, about 5 ongoing clinical trials, both academic or industry-sponsored, with interferon in MPNs, including PV and ET only, not in PMF to my knowledge. So we will probably learn much more with these prospective randomized studies on the toxicity of interferon, but until now, we haven't seen any new concern compared to what we know with millions of patients treated with interferon for hepatitis, for example, viral hepatitis. So we have the same side effects at a lower incidence, probably because the doses that are sufficient to treat patients with PV and ET are much lower, usually, than the one that were used to treat viral infections.